Welcome to Pathology Central, Key Concepts. The topic of this video is bone tumor basics. Now this will be a challenging video for me to give because I am actually a subject expert in bone tumors. And so there are so many marvelous things that I want to share with you about these incredible tumors and their biology, but I have to really rein myself in to keep this at a level appropriate for medical students. So I'm going to do my best. I'm going to begin by providing some context for you by correlating bone tumor biology and what we see morphologically and radiologically, because I think this will help you to understand how bone tumors work. I'm next going to take a few entities and compare and contrast some benign and malignant bone tumors so you can apply the learning of bone tumor biology to that. Now, there are lots of bone tumors, and this is a non-comprehensive list. The true list is probably about 3 times this number. And we divide these tumors up as benign and malignant, and furthermore based on the matrix they produce, so bone or cartilage, and then we also have a large category that we call other. Now, I'm going to focus on these entities in this video, and I'll explain why. So osteoid osteoma and osteoblastoma are really two ends of a spectrum. They're very closely related, and together they account for about 26% of benign bone tumors. Giant cell tumor of bone accounts for another 15 to 20%. So by looking at these entities, we're covering a fair amount of what you need to know for benign bone. And then osteosarcoma is obviously the most common primary malignancy of bone, and chondrosarcoma is the second most common matrix-producing tumor. So, and they provide a really nice compare and contrast. So with all tumors, we use a multidisciplinary approach. It's no longer just that one pathologist looking at something or one clinician looking at the patient. We all have to come together to bring all the data together so we can make the correct diagnosis. This is particularly important in bone, and I'll explain why as we go through it. So I can't simply just look at a slide and say this is a diagnosis. It's really helpful to have the clinical and radiological features. So for the clinical, I need to know the patient's age. I need to know not only which bone this is arising from, but where in the bone, so epiphyseal, metaphaseal, diaphyseal. And I'd like to know that whether it's painful. So was it a slow onset of pain? Was it an abrupt onset of acute pain, which is suggestive of pathologic fracture? For the radiology, what I really like about bone is that the bone tells you what that tumor is doing. Is the tumor growing very slowly so that as it grows and is perhaps dissolving some of the host trabecular bone, the surrounding bone has the opportunity to buttress that by a sclerotic rim? Or is it growing so quickly that it's permeating the bone and eating away at it, giving a moth-eaten appearance? I also like to know if there's soft tissue involvement, which is very strongly correlated with aggressive behavior. And then calcifications and the quality of those. Are they the popcorn calcifications we see in enchondromas? Is there calcification in a soft tissue mass, which strongly suggests osteosarcoma? So let's turn to our clinical. I mentioned age is important as well as the bone and the site in the bone. So looking just at this image here, and this comes from Dorfman and Cherniak's Bone Tumors, an excellent book for those of you who are interested in bone pathology. So looking at this figure here, I can see there's a peak incident in the age from 10 to 20 with a smaller peak in the post-50 range. And this tells me, even if I knew nothing else, this is the classic appearance of osteosarcoma. So it tends to affect adolescent males in the tibia and femur metaphasis, so these big black arrows, and it also is most common here in the proximal humerus metaphasis. So knowing this alone, I can say that I'm very suspicious that the tumor I'm about to be talking about is an osteosarcoma. Now, why is this relevant to you as a medical student or future physician? Because if you have a patient who, for example, has a lesion on the finger and they get a biopsy and the pathology report says osteosarcoma, you need to take another look. You need to talk with your pathologist, maybe get a second opinion, because they're very uncommon in the fingers and toes. So having this information is going to help you take better care of your patients. Now, if I look at this other diagram, we can see this is affecting individuals over the age of 50 and is primarily affecting the axial skeleton, so the ribs, sternum, scapula, pelvic bones. We also are affecting the femur But in contrast to what we see in osteosarcoma, where it's primarily metaphaseal, we can see that is diaphaseal as well as proximal metaphysis and epiphysis. And knowing this distribution and age distribution, I can tell you this is going to be a conventional chondrosarcoma. So that just comes from familiarity with this material. So there are some additional treats. So this is looking at where the tumors arise in the bone. So we have benign lesions here and malignant here with osteosarcoma. So I can tell you, and we'll look at the radiology of this, if I have a lesion that's arising in the metaphysis of, say, the distal femur with a soft tissue mass, that's osteosarcoma, right? They're almost always metaphaseal. Now that doesn't mean we can't see epiphyseal or diaphaseal, even intracortical osteosarcomas, but the vast majority will have this type of presentation. So that's going to help me make my diagnosis. For other lesions, I'm not going to go into any of these other than giant cell tumor of bone in this talk. The position where this lesion is within the bone gives some clues. So I'm going to show you a non-ossifying fibroma radiograph in a moment. Giant cell tumor of bone is nearly always epiphyseal and will break through the growth plate of skeletally mature individuals and can be an expansile mass. And chondromas arising here in this metadiaphaseal area. And then a lovely little benign cartilage tumor called chondroblastoma arises in skeletally immature patients, so young patients in the epiphysis. Okay, I'm already starting to get into telling you too much, so let's move on. So imaging, of course, is critical for understanding and diagnosing bone tumors, and we use all of the modalities. So X-ray is useful to let us see how is this lesion presenting. Is it lytic? So is it destructive of bone? Is it dissolving bone? Is it blastic? Is it making bone? So for example, an example of a blastic tumor would be a prostate cancer metastasis to the skeletal system, almost always blastic. Is it mixed, showing areas of lytic and blastic activity? And then the second thing we'll be looking at is, are we seeing an aggressive lesion or does it seem to be slow growing? Again, I already referenced that sclerotic rim. CT scans are great for imaging bones. MRI is really good for examining the extent of soft tissue involvement. And then radionuclide scans, PET scans can be useful for identifying metastases and areas of active disease. So let's look at this aggressive versus indolent story. So here we can see a schematic where the lesion is actually red. And this is a slow-growing tumor here in this particular example. What's happening is it's growing very slowly, which is, and it's affecting the structure and strength of the bone, of this trabecular bone, which is allowing the surrounding bone to form a sclerotic rim. So it's providing a buttress to deal with the strain of gravity on that lesion. Now, on the other end of the spectrum, we can have a moth-eaten or permeative approach, where we don't have a single lesion, where we have it just going through, and we have areas of tumor which are lytic and are dissolving through, so moving through the bone. Now, this is a spectrum, so we can also have one that it does not have sclerosis, which is just a simple punched out lesion, and that doesn't tell you as much. So a sclerotic lesion is going to tell you this is indolent. Permeative or moth-eaten is going to tell you it's aggressive. Just so you know, moth-eaten and permeative do not mean malignant, because we can see a similar image in osteomyelitis, but it does tell you that it is an acute, fast-growing process. Okay, so here is an example of a sclerotic lesion with sclerotic rimming. This is the non-ossifying fibroma. And here a little bit blown up. You can see we have increased deposition of bone. So we have this thicker white band because it's sclerotic. Something else you future radiologists will appreciate is that the growth plate is open. So this is in a young patient, which is typical for non-ossifying fibroma. In fact, this radiologic image is diagnostic and no biopsy is needed. Now let's compare that sclerotic area with what we see here. This is an osteosarcoma. We're going to go into this in more detail. What I wanted to show you simply in this video is looking at the interface of the tumor with the normal bone. So we can't really see where it is. We'll anticipate that this area is normal, so no tumor involvement, but we can't see where the tumor stops, because here's a little area that's a little lytic. Could that be some tumor? We have a lytic area here. There's a little bit of density there. That could be a little bit of bone formation. And again, we do see bone formation in the soft tissue. And I'm going to go into this in more detail when we look at osteosarcoma. Okay, but the primary goal of this image was to show you this permeative non-sclerotic border. All right, so with that, let's go for conventional high-grade osteosarcoma. Now, you may be wondering why I refer to this as conventional high-grade osteosarcoma. It's because I'm a specialist and I know there are multiple types of osteosarcoma. Just know that for where you are in your career, just knowing something is an osteosarcoma is good enough. And when we call something an osteosarcoma, almost all of them that we'll be referring to are what are called conventional high-grade. As I said, it's the most common primary malignant bone tumor, about 20% of cases. RB mutations are seen in about 70% of sporadic osteosarcomas. I have a video just on RB that I can recommend for you to watch. As you recall, TP53 mutations in the germline are seen in Li-Fraumeni syndrome, and these individuals are at increased risk for osteosarcomas. P53 derangements can also be seen in sporadic osteosarcomas, either through epigenetic silencing or through mutation. And histologically, for where you are in your career, all you need to know is that conventional high-grade osteosarcoma is going to be characterized by malignant cells plus osteoid, because they are malignant osteoblasts. What do osteoblasts do? They make bone, so we look for osteoid to make sure that's what the lesion is. Now I'm going to talk a little bit here about therapy. Back decades ago, when someone presented with an osteosarcoma, the treatment was immediate amputation. But patients didn't tend to do very well, even though the primary lesion was removed, and that's because about 90% of individuals had occult metastases at diagnosis, primarily to the lungs, since sarcomas, including osteosarcoma, tend to spread hematogenously. So what we do now is we give chemotherapy and then we do limb salvage surgery. So the idea is neoadjuvant means we give it before. Adjuvant therapy is therapy you give after surgery. And there are a couple of reasons why we do neoadjuvant therapy. One is to shrink the tumor so that we can do limb salvage, so that the tumor is smaller. We have a greater opportunity to spare the limb. The other is that tumor prognosis is closely linked to how well it responds to this neoadjuvant chemotherapy. So when we get an osteosarcoma resection, we will map out to see how much necrosis there is. If there's more than 95% necrosis, that's a great response, and we expect a good prognosis. If necrosis is less than 90% and much of the tumor is viable, then we think that perhaps a different chemotherapeutic agent needs to be used, and perhaps adjuvant chemotherapy. Okay, so let's go back to our map. As I mentioned, we have this peak incidence in the age of 10 to 20. It does tend to affect males more than females. This is during the period of the growth spurt, and keep in mind that males do tend to grow more than females, and that most of that growth is going to be around the knee, so around the distal femur and proximal tibia. Is it a coincidence that this is the area where we tend to have most osteosarcomas? You have a lot of cell proliferation going on, perhaps mutation, and therefore we get our osteosarcoma. And as I mentioned, you can also see it here in the proximal humerus, and it tends to be metaphaseal. So here again is our image showing us, this is diagnostic to my mind of an osteosarcoma. As a pathologist, if I saw a biopsy from this that was not osteosarcoma, I would say they've made a mistake. That the tissue was switched in the labs, or that they missed the lesion entirely, which would be difficult for something this large. Now you can see this are clinical, so these can present as a large mass, which this patient clearly has. We have calcification in the soft tissue, so this tumor, which has originated here in the metaphysis, has broken through the cortex and has soft tissue extension. Now I'm going to draw your attention here to this arrow. This is a Codman triangle, which I'll be talking about more in a moment. But just to let you know, this is showing the periosteum. Now the periosteum is closely opposed to the cortical bone. As tumor grows through the cortex, it's going to lift that periosteum. The response of the periosteum to this stress is to lay down reactive bone. And it's not something that you see just in malignancy. So in children who have osteomyelitis, as the infection percolates through the cortical bone, it too will lift up the periosteum, and we will have reactive bone that is non-neoplastic. And that bone is why we actually see a shadow here, because there's calcification here. Now on this resection specimen, you can see again, this is a tumor that arose in the metaphysis. So if you look just based and expecting sort of centripetal growth, it probably originated about here. It is broken through the cortex and has a large soft tissue mass, which has hemorrhage, as well as sort of a very heterogeneous appearance. This is probably some bony formation and then a fleshy tumor here. Now to look here, we see our common triangle again. What happens here is we have lifting of that periosteum, reactive bone here, and then the tumor is going to eat through not only the cortex but the periosteum, extending into the soft tissue. So here's a little cartoon that I drew for my medical students. You can see here the tumor is lifting our periosteum. This is reactive bone. There's the tumor. And let's take a look at the histology. So just to orient you, this is cortical bone. So here is our medullary canal. Tumor is coming from here, percolating through and forming a soft tissue mass. And then here is the periosteum, which has been lifted. This is non-neoplastic reactive bone. And this is viable tumor, which here has eaten through that periosteum into the soft tissue. Now let's look on higher magnification. This is the reactive bone, so lamellar bone, which is non-neoplastic, and then the tumor cells percolating through. Let's look here on higher magnification, which gives me an opportunity as well to point out the osteoid. So osteoid is going to be this dense pink material. So it's non-mineralized bone. Even if this did have some calcium to it, we can't cut that, so we will decalcify the specimen, and that's in part why these cells look so blown apart. The treatment that we use to decalcify bone is very hard on viable tissue, so they lose a lot of their features. But this is the lace-like osteoid here. Let's look at another image that has not been as brutally decalcified to give you another image of osteosarcoma. So here is the pre-existing trabecular bone, and this is the lace-like osteoid that these malignant osteoblasts are laying down. Here you can see an atypical mitotic figure and cytologic atypia. Okay, so that brings us to the end of osteosarcomas. Now let's do a compare and contrast with conventional chondrosarcoma. So when I say conventional, what I'm referring to here are chondrosarcomas that typically arise in the intramedullary canal. Now I'm going to also refer to a couple of other types of chondrosarcoma as far as their origin. So chondrosarcomas can arise in that intramedullary canal. They can also arise on the cartilaginous cap of osteochondromas, and they can occur in the setting of chondromatosis. So more about that in a moment. So all of these are going to make malignant cartilage, and they typically will present as painful, slowly growing masses. As I mentioned, you can have sporadic conventional chondrosarcomas, and these, as well as those in which that arise in chondromatosis. So in chondromatosis, patients have multiple enchondromas throughout the skeleton. In both of these situations, we can see mutations of IDH1 and IDH2. As you recall from the neoplasia chapter in Robbins, what these mutations do is they cause the synthesis of what we call an oncometabolite, 2-hydroxyglutarate. What this new metabolite does is that it interferes with regulation of DNA methylation and therefore changes the pattern of gene expression. So we can see these mutations in both sporadic and chondromatosis-associated chondrosarcoma. Now, multiple osteochondromas are a syndrome associated with germline EXT mutations. What these mutations do is they decrease the amount of heparan sulfate glycosaminoglycans. The role of these glycosaminoglycans is to regulate cartilaginous growth, and so we see these mutations in chondrosarcomas arising in this setting. Now, as with all tumors, prognosis is very closely related to stage. So something is low stage at diagnosis, that tells you something about that tumor's behavior, whereas if it's at high stage, it doesn't really even tell you prognosis. It tells you it's an aggressive tumor that has already moved on. When we are talking about conventional chondrosarcoma, looking at all comers, we want to look at the grade, because grade is going to give us a lot of information about how this tumor is going to act. So we have 3 grades. Grade 1 is well differentiated, grade 3 is poorly differentiated, and for those that have a grade 1 tumor, the 5-year survival is about 80 to 90%. By contrast, in poorly differentiated or grade 3 chondrosarcomas, 5-year survival is about 43%, mostly because these patients typically have metastases at diagnosis, so they're high stage as well as high grade. And the treatment for conventional chondrosarcoma is surgery. They don't respond particularly well to chemotherapy. Now here's our cartoon again, occurring in individuals over the age of 50 and affecting the axial skeleton predominantly. And as I mentioned before, we see it here in the femur, but it can affect the diaphysis as well as the metaphasis and epiphysis. So let's look at the radiology. So I showed you permeative and sclerosis. I didn't show you what chondrosarcoma looks like. It has a different appearance. What happens is they tend to be slowly growing, and they're going to be putting pressure on the cortical bone, which is going to thicken and will have the scalloping. This is referred to as end osteal scalloping. Also, one of the things that cartilage does is it makes calcifications, and we refer to these as popcorn calcifications. So we can see this calcification in here. Compare that to the normal intramedullary canal here. So you can see here, if we look at healthy bone, that the interface between the cortical bone and the medullary canal is a straight line. Here you can see scalloping. And we also can see areas, this looks a little bit lytic, and then we also have some calcification here. Now, grossly, this is a sternum. And the cartilaginous tumor, this chondrosarcoma, has eaten through the cortical bone to form a soft tissue mass. It has these glistening nodules of blue-gray tissue, which look very similar to what you'd see on a resection specimen for degenerative joint disease, so like articular cartilage. And then microscopically, we see these nodules of tumor which are pushing through and permeating around the pre-existing trabecular bone. And on higher magnification, you can appreciate the cytologic atypia, the variation in size and shape, as well as the fact that the matrix has this sort of loose liquid appearance to it. This myxoid characteristic is something that we associate with chondrosarcomas. Okay, so that brings us to the end of our two malignant tumors. Now let's turn to the two benign tumors I'd like us to consider. These are beginning with osteoid osteoma and osteoblastoma, which I'm treating as a single entity. They're both benign and they have similar histologic features. However, they have different sizes, so by definition, osteoid osteoma is less than 2 centimeters in diameter, whereas osteoblastoma is larger than that. They arise at different sites, so I'll show you our cartoon in a moment, and they have different symptoms. So one thing we know about osteoid osteomas is that they produce prostaglandins, which cause pain, which is typically worse at night, and they respond beautifully to nonsteroidal anti-inflammatory drugs. By contrast, osteoblastoma, which also can be painful, does not have a significant response to NSAIDs. We don't know the pathogenesis of these lesions. Radiologically, we're going to have a targetoid appearance with a central lucency with a central sclerotic nidus, so a little target at the middle, and sclerosis on the rim, and I'll show you an image of that in a moment. Histologically, we have interconnecting trabeculi of woven bone with abundant, somewhat unusual appearing osteoblasts because they're very revved up. So let's take a look at our cartoon first. So you can see here that there's a different distribution of these two entities, even though if I were to look at one on a slide without the information, I couldn't tell you whether it was an osteoid osteoma or osteoblastoma. So osteoid osteomas tend to affect individuals from the age of 5 to 25 in contrast to the older distribution of osteoblastoma. The primary bone affected will be the femur for osteoid osteoma, although we can also see some in the tibia as well as in the humerus and even in the hand. By contrast, osteoblastoma is much more common in the vertebral column, primarily in the posterior elements of the vertebrae. I can also see it here in the feet. So I mentioned the radiology. This is a specimen radiograph. So the way that we treat these are intracortical lesions, is to excise that cortical lesion. Because as I mentioned, this is an osteoid osteoma. They can be quite painful. So first, let's look here at the center of the target. We have a little sclerotic nidus surrounded by a lucent area. And then we have bony sclerosis all around that. So this is responding to mediators put forth by the tumor as well as to that to the lucency. So that's affecting the structural integrity of the bone. And because these are slow growing, we have plenty of time to develop the sclerotic rim. This is what we see histologically. We have these trabecular bone interwoven trabeculi. And they are woven bone, not a lamellar bone. We have a couple of bonus osteoclasts here, but look at these osteoblasts, how large and juicy they are. They are really working hard to put down bone. Okay, so this brings us to our final entity, which is giant cell tumor of bone. So this is also a benign lesion. There are very, very rare instances of malignant transformation, so just go ahead and think of this as benign. It's locally aggressive, and it's really characterized by sheets of multinucleated osteoclast-type giant cells. Now, there has been some discussion in the past. Is this reactive? Is it neoplastic? The general consensus is, based on genetic findings, it is neoplastic, although we don't know the pathogenesis. And the neoplastic cells are putting out a lot of rank ligand. Now, if you'll recall, what rank ligand does is it drives the proliferation of osteoclast precursors and then their differentiation into osteoclasts. So you're bringing forth this sea of osteoclasts into a very local area. Now, typically we have a balance between osteoblasts and osteoclasts. Here we just have sheets of osteoclasts that are going to be dissolving bone. Tends to affect adults, so the growth plate is closed, in contrast to chondroblastoma, which I mentioned in passing, and which happens in children, and it arises in the epiphysis. Radiologically, we're going to see an expansile mass that destroys the cortex, and then, as I mentioned, basically sheets and sheets of osteoclasts like giant cells interspersed with mononuclear stromal cells. Now, the treatment for this is typically curettage, so the surgeon will make an incision and scrape out everything there, perhaps add some sort of caustic agent to kill any residual cells. And even with this, about 40 to 60% will recur locally, and something which can also be concerning is that about 4% will metastasize to lungs. However, unlike metastases of other sarcomas, such as osteosarcoma, they have a very indolent course that may even spontaneously regress and typically do not kill the patient. For these types of tumors, we can use rank ligand inhibitor medications for metastatic disease or for ones that cannot be easily resected. So here we see our distribution, again, past the age of 20, skeletally mature, primarily arising in the epiphysis of the distal femur and proximal tibia, but also interestingly here in the sacrum as well as the distal radius. Here we can see our radiology. This is arising in the fibula. And you can see this expansive soap bubble type lesion. So we don't see what we see in osteosarcoma, where the tumor blows through the cortex, forming a soft tissue mass. We retain this thin shell of bone around the lesion. That can fracture. In fact, we actually do have a pathologic fracture right here. So this patient may not have noticed this fullness in the posterior calf, but certainly with this fracture felt pain. And this is what we see histologically, are these sheets of osteoclasts that are dissolving bone admixed with these mononuclear cells that may be the precursors that haven't fused yet. Probably scattered in here are some of the neoplastic cells. So this brings us to the end with the questions, and I'd like to ask you, what are the radiologic features associated with aggressive behavior and also with benign behavior? What causes a Codman triangle? And which of the tumors we've discussed are common in children and adolescents and which in older adults? I hope you have found this useful. Please follow me on Twitter, shoot me an email, and check out my website. So thank you very much.